Good afternoon. Welcome to UCSF Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Hope everyone's doing okay out there. Although things have begun to turn around COVID-wise in San Francisco, the hospital is still about as busy as it's ever been with over 100 COVID patients. And I know people are incredibly busy, and a lot of folks have been sick or families have been sick and are out. And so it's a very, very tough time. Hopefully things will start turning around. Before we start Grand Rounds today, let's go ahead and put up the ground rules. I think everybody knows these by now. If you have questions, put them in the Q&A box. Closed captioning is available. The session will be available on YouTube later, next day or so. And I think that CME credit will be available to those who want it. If you're interested, stay on after the talk ends, and we'll show you the instructions for doing that. Today's not a COVID-specific session. We're trying to focus those the first Thursday every month. So next month, the session will be on the current Omicron surge in state. George Rutherford, Peter Chin-Hong, and Sarah Dornberg will talk about the state of the pandemic and answer our questions about things like masking and boosting and testing and therapeutics. But in today's session, we'll consider some of the lessons from COVID from a very different angle. Our speaker is someone whose work I've admired for decades, Wes Ely. Wes is professor of medicine and critical care at Vanderbilt and co-director of the Critical Illness, Brain Dysfunction, and Survivorship Center. He's also associate director of the Aging Research Program for the VA's Geriatric Research Education Center. I have followed Wes's work for must be 20 or 30 years, and I see him as the person probably most responsible for changing the way we think about the intensive care unit, not only its miracles and its benefits, but also its potential harms. And someone who has really done an amazing job reminding us that the ICU is a unique blend of technological miracles with stories of the human experience in all of its flavors. Wes recently wrote a book that told many of the stories and lessons from the ICU. It's called Every Deep Drawn Breath, and I highly recommend it. I think it's terrific. It was reviewed in the Washington Post by, it turns out, my wife, Katie Hafner, and she wrote, "Pandemic or no, most Americans will in their lifetime be a patient in the intensive care unit," which makes Wes's book a timely book, its message an urgent one, and I think that is very true. Wes is giving grand rounds today, but also is a visiting professor virtually, and so has already met with and will continue to meet with a number of our faculty, our care teams, and our trainees, and the feedback has been spectacular. His talk today, so thank you, Wes, for doing that, and his talk today is entitled "Rebuilding What We Lost from COVID, A Perspective from the ICU." So Wes, why don't you come on and join us?
Fantastic. Thank you for having me. I appreciate people taking time out of their busy life to take a moment to reflect on what we have lost during COVID and what I hope will be a message of a way to build our way forward, to dig out of some of this loss that we've all experienced. And it's been very interesting for me here in Nashville today at Vanderbilt to talk to so many of your faculty and staff about what you're going through, from leadership like Lakshmi Santosh to Dr. Wachter himself, to many other physical therapists, occupational therapists, respiratory therapists, nurses. And what I've learned and what you've just told me and taught me is just how much pain and suffering you're going through as healthcare professionals. And I think that we all are carrying around both that element of burnout, but in addition to that, some element of moral injury, because we feel like that some of the ways we're being asked to care for other human beings is not the way we were trained or taught, and that maybe something is lacking in what we're doing in service of our brothers and sisters. And so the message today is going to go like this. I'm going to try and share with you a bit of my own reflection and journey that led me to kind of carry shame and guilt as a physician in the intensive care unit, as what I call myself a geriatric intensivist. I was trained by some of the great geriatricians in the world, and they kept a lens on my camera to look for the most vulnerable patients that I would care for and to amplify their human dignity at every step that was possible. And what has happened is that we've worked for 20 years to design large, multi-center, international clinical trials to improve the way we cared for people. Let's face it, all of us on this call today will probably have upwards of 2 ICU admissions in our lifetime. We will all know people in our life, loved ones, who will go through the intensive care unit, and we'll care for patients. Whether you're an ICU doctor or not, you're going to care for people who either land in the ICU or you're going to see them on the back end when they're in your clinic. And what I hope that will happen today is that you will be able to connect the dots on their life complaints, their quality of life things, that you can say, wow, some of that stemmed from the ICU. Let's unpack that and give you a way of looking at it that will help you become a more whole healer and see the entire person. So those are my background thoughts. I want to start with a 2-paragraph commentary from the author note of this book that I wrote, Every Deep Drawn Breath, which, as Dr. Walker said, all the money, all the proceeds, 100% net proceeds are going to an endowment for COVID survivors and their families to try and pick up the pieces of their life. Many people believe medicine is grounded in benevolence, that is, wishing good. It is more than that. The target principle of medicine must be a higher standard, beneficence, doing good. This breeds trust between my patient and me, which is the cornerstone of my art and practice. In return for her trust, I promise always to help her and never harm her. Every time I step into the hospital, I remind myself of the enormity of this promise, this covenant. Early in my career, I strayed, not intentionally, but out of a desire to control every medical circumstance. I didn't listen well enough. Our greatest treasure is found in deep, real communication with each other. When this is nurtured, especially in times of suffering, 2 people can establish something of almost mystical quality, a reciprocal connection that brings us to a place of charity and empathy that crosses cultural, social, and racial boundaries. And without such communication, we remain miles apart. The reason I read that to you was that what I'm going to tell you today is the tale of how we worked very hard to rehumanize the care that our world's sickest patients get, only to see it torn down by the pandemic. So much so that I'll give you a glimpse into what I'm talking about data-wise. In 2019, we published a paper showing that across 50 countries that we had achieved 70 to 80% compliance with this safety checklist that we had built through 400 peer-reviewed papers, 35 to 40 New England Journal, JAMA, and Lancet papers. It's called the A2F bundle. That's the way I abbreviate it, or the ABCDEF bundle, a 6-step checklist that your pilot might use to get you safely in the airplane from LA to New York, or in your case, from San Francisco to New York. And we had achieved such good compliance, and we had these data and tools translated into 40 languages. And we just published a paper several months ago showing that in COVID times, we're now down internationally to 10 to 20% compliance. So I'm speaking from an evidence-based perspective to say that we lost something huge, and it has 2 major prongs of problems. One is that, to be selfish for a moment, it puts us at risk for burnout and not finding fulfillment in our careers and moral injury because we know we're harming patients. But of course, more importantly, it's the patients who are suffering. And if the patient is our North Star, and I firmly believe that my patients are my North Star, then they are not receiving safe care because of what COVID did. So I'm going to unpack that for you, and I'll bring it to a close and leave us hopefully about 20 minutes for Q&A. And I promise that we will dive into things, so get your questions ready. So I'll read you 2 patient stories, and I'm going to tell you the medical history of how we did this. My father left us when I was little, and my mom had to raise the kids with basically $17,000 a year, no money. We lived in a 4-room house, not 4 bedrooms, just 4 rooms in Louisiana. That's how we say it down there. So I became a farmer. I was working on the farms. I was throwing hay, picking, and I worked with these pickers all the time. And I was reading in a book club that my mother established for us, Maya Angelou's I Know Why the Caged Bird Sings. And Maya had been silenced by trauma in her life. And I looked at the pickers and realized that they were silenced too. They were suffering from a form of testimonial injustice, which is to say that society had kind of placed a thumb down on them and they were unable to get out of their circumstances, so that small cuts and tooth abscesses became gaps and smiles and cellulitis and oozing fly attracting wounds. And I saw all that and thought, I've got to go into medicine. I'm going to try and use what I've got to bring a voice to these voiceless people that I'm reading about and seeing. So the first of the two stories. In my third year of medical school, my first patient was Sarah Bollock. Sarah had grown up in a clapboard shotgun house on Desire Street in the 9th Ward in East New Orleans. She was 23 years old with a 1-week-old baby and should have been at home bonding with her newborn child. Instead, she huddled in a brown blanket in an open ward intensive care unit, Charity Hospital, of course, in profound shock. Sarah was sick with peripartum cardiomyopathy, a rare and deadly disease of the heart muscle that occurs in a small number of pregnant or postpartum women. When I first met Sarah, she looked at me, her eyes full of fear, as if she were praying for help but couldn't get the words out. She was terrified she was going to die. We were the same age. And I go on to describe how I was titrating her dopamine by hand. We had no electronic pumps or anything. And then I get down to this. Beyond the curtains pulled tight around her bed, the busy world of the ICU pulsed and beeped, all noise and movement. But in here, my focus was on her. I held her right hand, and she gripped mine, her palms sweaty with fear. "What's happening to me, Dr. West?" she asked again and again. Or, "Why can't I be home with my baby?" Unsure of myself and my nascent knowledge, I fumbled through some facts. Her blood pressure was too low. Her heart was failing. We hoped it would improve. We both knew she was likely to die. I could see it in her eyes, and I'm sure she could see it in mine. But she continued to trust my medicine and me. And the reason I chose that is because of that last line. She was trusting my medicine and me. And really, I didn't have anything to offer her. So all I had was myself to enter into relationship. And I believe my working definition of mercy is to be willing to dive into the chaos of my patients' lives and provide lifting and healing. And if I'm asked to dive into the chaos and not give the lifting and healing, then I think it's a false mercy. And what I'm going to share with you in this second story, and then I'm going to tell you the medical history of what I did in response to this next experience, is that I think I provided false mercy for this patient. So a young woman named Teresa Martin came to me once I moved on to my internship, and she was a TCA overdose. She had aspirated, she had ARDS. We cared for her very aggressively with life support, and I thought I was doing everything that I was supposed to do. She ended up with blown up lungs, 7 chest tubes, all kinds of problems. And I actually found in the writing of this book my own handwritten clinic notes or ICU notes from 20 years ago in the 1990s. And I have this sentence highlighted because I'm so ashamed of what I wrote and what I didn't know or understand. After all of that had happened, my off-service note says, yada, yada, she's this sick. And it says, however, and I wrote this in my own hands, amazingly enough, the patient still manifests only single organ damage, lungs, with good renal, GI, CV function. So I thought she was okay, except for her lungs. Now listen to the description of what happened when 2 months later, after more time to heal, she came back to see me in clinic. She rolled into the room in a wheelchair, pushed by an aide, her mother at her side. She gazed ahead, heavy bags under her eyes, a shell of a young woman. And by the way, think forward to 2022 with our COVID patients and their survivorship, because it's not very far off from this. And that's why I say we lost a lot of ground. No greeting, no smile. She turned to me with a blank stare, and I wasn't sure if she remembered me at all. Almost immediately, Teresa's mom asked, why can't she bend her arms at the elbows or move her shoulders? Her mom looked drained, more tired even than when she visited her daughter in the hospital. We ran through a litany of other problems that Teresa was having. She couldn't swallow properly or sleep or go to the bathroom alone. She couldn't shower or dress herself. She could only walk a few steps at a time, and stairs were impossible. The list of ailments was dizzying. I had no immediate solution for any of it, and even less of an understanding of where the problems were coming from. So I did what I knew how to do. I ordered blood work and x-rays. The labs didn't show anything alarming, but the x-ray images of her arms, legs revealed calcium deposits in her elbows, shoulders, and knees. Teresa had heterotopic ossification, a condition in which bone develops where it shouldn't due to extreme inflammation and prolonged immobilization. It was as if she had rocks growing inside her joints. I'd never seen anything like it before, and I didn't know what to think. So this woman's life was destroyed in large part by iatrogenic injury that we had imposed upon her because of the immobilization and the deep sedation. And what happened in my life as a physician was that over the ensuing decade, through the 90s, I began to get more and more bothered by the fact that I knew that I was causing harm and that my medicine, our medicine, all of us, we were contributing to this injury. So around the end of the century, 1998, 1999, my wife, who's a pathologist, got this job at Vanderbilt, and I came here and got to work with some really iconic people in the field, people like Gordon Bernard, Robert Dittus. And I decided that what I was seeing in clinic was that all these people came back and they didn't know, they weren't thinking clearly. They had to quit their job. They were not functional at their job and they were retiring early. So I said, something's happening to their brain. And we developed a way to measure delirium in the ICU. A lot of people said this was a crazy idea and a career ender and something stupid to do. But I just couldn't get around the fact that something was wrong with Teresa's brain and these other patients' brains. So we published in JAMA. Here's now the litany of the literature that builds us up to 2019. So in 2001, we published a paper in JAMA on the CAM-ICU, or the Confusion Assessment Method for the ICU. It's a 37-second tool at the bedside where we can diagnose acute brain injury, acute brain dysfunction. Then in 2003, we published a paper with the RASS, the Richmond Agitation Sedation Scale. Kurt Sessler invented that from Richmond, the Medical College of Virginia. He was going to call it Sessler's Agitation Sedation Scale, but then it would have been Sessler's ass, so he didn't do that. So we call it the RASS now. And the RASS and the CAM are two of the tools we use in the ICU to this day to measure how somebody's brain is doing. And in 2004, we published in JAMA the first paper to show that the longer somebody was delirious, the more likely they were to die, even after adjusting for covariates like severity of illness and other obvious things that could be causing problems, specific injuries, et cetera. So now that we were armed with a way to measure this brain dysfunction, and we knew that it mattered, and by the way, a take-home numerical thing to remember is that every additional day of delirium in the ICU increases your risk of dying by 10%, independent of other covariates. And every additional day of delirium increases your risk of long-term cognitive impairment by about a third, 30%. So we knew that we needed to reduce the amount of delirium. And the first thing we did was we said, well, in 1996, I had published a paper in the New England Journal. It was my chief resident research project that was on spontaneous breathing trials, where we just turned the breathing machine off once a day. And then in 2000, J.P. Kress from University of Chicago published a paper on turning the sedation off once a day. Each of those studies had shaved 2 days off the ICU stay. So I wondered, well, what if you put them together and we turn the drug off and then we turn the vent off? And we would call that an awakening trial and a breathing trial. So step A, step B. We put them together and we published in Lancet in 2007 the first paper that showed that you could save lives by turning off sedation. It was a very cool observation because it wasn't a tiny life savings benefit. It was huge, 15% absolute risk reduction. Then we started saying, well, let's mess with the drugs we're getting. So we're giving all these people benzos. Why don't we just quit that and use different drugs? So we've looked into things like narcotic only and alpha-2 agonists, think like dexmedetomidine or clonidine, or there's even other drugs right now that we use that are alpha-2 agonists for ADD that we're now studying in the ICU as well. Guaifenesin, for example. And so we've then published a series of multiple papers in JAMA showing that we could reduce delirium and coma, reduce length of stay in the ICU on the ventilator. And these studies, the MENS trial, the SEDCOM trial, and then a paper in Lancet by Thomas Strom from Scandinavia that showed that you could use no sedation other than just a little bit of morphine, and that you could reduce the amount of overall functional dysfunction, functional disabilities in patients if you would reduce the sedation. So between 2005 and 2012, that was the era where we learned that sedation was creating this havoc. It was like a grenade going off in these patients' bodies. And in 2012, Dale Needham and a group from the Society of Critical Care Medicine finally defined the syndrome that patients were experiencing after survival. It's called PICS, or post-intensive care syndrome. And this PICS is when somebody gets really sick, whether they be in the ward or the ICU, and they develop, while they're under our care, under our noses, they develop the acquisition of dementia, PTSD and depression, and then neck down, physical and muscle and nerve disease. So we call that ICU acquired weakness, which is a motor sensory neuropathy. When we had this defined in 2012, which is basically what Teresa Martin had back, in the 1990s when I cared for her and saw her come back to clinic all broken. Now that we had a name for it, we said, well, let's start trying to reduce PICS and start trying to take this forward in terms of an overall program in the ICU. And we started building the ABCDEF bundle. I had read Malcolm Gladwell's book, The Tipping Point, and he said in the book, you got to make something sticky if you want it to take hold. And so there's nothing more sticky than the alphabet. And he said you need salespeople and you need people who are mavens who know the expertise. So we started building teams of the mavens and the salespeople and the sticky message. And we turned out that Gordon Moore, the billionaire who founded Intel, got sick, and in his ICU experience, he had a very bad delirium and he wasn't allowed to see his family. And he got out and said, look, I'm going to put some money to this and you guys got to go fix it. So the Society of Critical Care Medicine, with a large team of people, Matt Aldrich, who's a wonderful leader in this area, and Heidi Engel, who's a physical therapist extraordinaire in your center, have all been leaders here. And there's many other people to name. I'm sorry if I'm leaving people out, but just in the interest of time, I'll keep moving. And across the country, we put 15,000 people into a collaborative whereby we proved that this safety bundle could reduce death, reduce length of stay, reduce delirium and coma. It even reduced ICU bounce backs, and it reduced the transfers to nursing homes so that people were going to their house instead. And that led us all the way up to the 2019 paper that I told you about, where we had such great compliance. And this is described in every deep drawn breath, but I'm not going to read anything more about that, just to say that it had become accepted that this is an evidence-based approach to reduce randomness in a place that's crazy, nutty, high stakes decisions. And we were really kind of getting our game on about how to take care of people better and produce a better survivorship. Well, I think, and I was talking to some of your attendings yesterday, they said, when COVID happened, what occurred was that people were in a survival mode and they were approaching it. And, I don't want, the war analogy is overused, but yesterday, one of your attendings said to me, we felt like we were in a mass casualty situation. And I think he had a great point. He said, because I was listening to him carefully. He said, when we're in mass casualty, we tend to think that anything goes, and that the former rules that we had applied to ourselves, derived from the literature, no longer hold. We're not bound by them anymore. And so we started just saying, well, we don't have PPE. People can't go in the rooms now because we don't have enough PPE. So we're going to triage who gets to go in the room. So the E and the F in the bundle is early mobility, and F is family. Well, all of a sudden, family weren't available because we limited visitation. And the physical therapists and occupational therapists to early mobilize the patients weren't going in the room either because of the absence of PPE. And all these new people came into the ICUs as new nurses, new interns, new people on our team. And they said, oh, this is how you do ICU medicine now. Okay, so you leave them in the bed, deeply sedated, not walking them, and that's okay. In COVID, that's how we do it. And then what happened was Helms published a paper in the New England Journal of Medicine at the very beginning of the pandemic, which said that in France, upwards of 90% of patients who were COVID in the ICU were receiving benzodiazepines. Well, just a year earlier, I had 3 seasoned ICU nurses who told me they had never, ever used a benzo drip. I thought, wow, we did it. We got rid of this bad drug. If you look at the 30 randomized control trials plus of benzos against anything else, they have never won. Not one time have benzos been superior to their comparator. And yet now in COVID ICUs all over the world, people are getting benzos again. So that's where we are now. We've lost a lot. And what I'm going to do is stop and share some slides with you to very quickly kind of juxtapose some wins and losses. And then I'm going to show you a short video and bring it to a close for Q&A. So let me share my screen. I want to start by just any relevant disclosures, because I'm going to tell you about a drug discovery program we did. I have NIH funding to do this study called Cove Barrier. I received no support from Eli Lilly at all. I refused any monetary support there. So what I'm telling you has no financial conflicts of interest. Always there's academic conflicts of interest. I do disclose Pfizer and Orion have given me honoraria for CME activities in the past, and I don't have any stock or paid consultancies with pharmaceutical industry. So partnership and progress in COVID resulted in some pretty cool things. The pinnacle of which is vaccinations, of course. But let me tell you about another story that I got involved in. Early on in the pandemic, a guy named Justin Stebbing in Lancet published a paper where they used benevolent AI, artificial intelligence, and machine learning to try and explore multiple different drugs that could be repurposed for COVID. And as you can see in this figure at the bottom, baricitinib has the largest circle. So baricitinib won, and the computer just said, this is going to be a great drug because of some anti-inflammatory and some antiviral properties that involve, of course, myeloid dysregulation, endothelial inflammation, and antigen presentation, which we think is all part of the disease. So because of this antiviral and anti-cytokine effect, we designed, I and a guy named Vince Marconi, who's a professor of infectious disease from Emory, who it turns out with the HIV world had been looking at JAK inhibitors for HIV inflammation for about a decade. And I'm sure there's some people on this call who know way more about this than I do. Anyway, we thought, why not randomize people to placebo of this drug that the computer picked? It's a once-a-day drug. It has a 12-hour half-life, and let's see what happens. So we partnered with Lilly, and we made a deal with them, by the way. If this works, we want people in lower middle-income countries to get this drug for free. So hang tight on that. 12 countries, 101 sites, and what we found in two papers, one of which is already out in Lancet Respiratory, and the other of which I've just finished the galleys on, is that out of 1,525 people randomized to placebo versus Bari, all of whom were hospitalized and on oxygen or more, the number needed to treat was about 20 to save an additional life. If you only looked at the subgroup of people on BiPAP or high flow, so higher illness, the number needed to treat is 9 to save an additional life. And along the way, when we were doing the trial, the FDA said to us, well, why don't you study people on the ventilators? Because nobody is studying people if they're already that advanced. So we set up a separate sub-study, which we consider exploratory, which is this next paper, which is about to come out. And that's the third row down at the bottom there. And we had a number needed to treat of 6 to save an additional life in that arm. So I think it's a really neat story of progress and hope that we used AI, the computer itself, to pick a drug, and then we tested it in Act 2 with remdesivir, and we found a benefit. Then we added it to steroids and found benefit in death reduction. And now Act 4 is going to come out with Bari versus steroids. We'll see how that looks. And now the drug is made available, a free PO drug, to the countries in Africa, India, Asia, Haiti, which is near and dear to my heart because I do medical work down in Haiti. And I just think that's a good story from COVID. But we have, and by the way, the WHO, the World Health Organization, updated their recommendations last week so that in severe and critical illness with COVID, that you couple with corticosteroids, either IL-6 receptor blockers like Toci or baricitinib. So we're moving ahead, but there's a way we're moving back, and there's splintering and regression in this next story. So 30 to 50% of people after critical illness end up with cognitive impairment that looks a lot like an acquired dementia. The neurocognitive domains are executive dysfunction and memory. They also have quite a bit of trouble, and they struggle with PTSD and depression. So the way the history falls out is that on the left side of the slide, you can see that from 2000 2014, delirium rates were incredibly consistent in ICUs at around 70 to 80%. Once we got the A to F bundle going and achieved this high compliance in those years just preceding COVID, we were down very consistently in multiple multi-center clinical trials and cohort studies to seeing delirium rates of ventilated people in ICUs in the 40s. So decades of consistent delirium had been reduced by a third to a half. And then COVID came out and boom, we're back up in the 80s percentiles and people are using the benzos again. So some investigators from Spain contacted me and said, Wes, let's do a study of this. And we eventually published this COVID-D study. And in the interest of time, I'm not going to dive into a lot of this, but it's a prospective cohort study that we did of 2,100 patients. And by the way, I was never on Twitter prior to COVID, but they said if I got on Twitter, we could enroll more patients faster. And I became a believer. I know Dr. Wachter is extraordinarily effective at this, but we enrolled these 2,100 patients via Twitter in 2 weeks. I was just floored by the power of the tool if used appropriately. So these people were very sick. They were in a coma and delirium for the bulk of 2 weeks. They were on benzos and propofol like crazy. But the saddest part is that we already saw in early COVID that we had dropped down on the bottom two rungs of this slide to less than 1 in 4 getting their drugs and ventilator turned off every day, which just prior to COVID had been considered usual care, and every patient every day should be respected enough to turn these drugs and ventilator off to see if they still require this life-saving, the life-saving therapies. And less than 1 in 20, less than 1 in 5 were getting any family association at all. So by multivariable analysis, the two highlighted yellow lines there showed that benzo infusions were increasing delirium by 60%, and the presence of family would reduce delirium, or likewise, the absence of family was increasing delirium. So this is Maslow's triangle, which many of you know, the famous psychologist triangle here. And I show you a picture, an actual picture of a nurse shown. She tweeted this out, and I've received permission from her to use her picture now. We've connected with one another. That's her pre-COVID and during COVID. And the reason I show this picture is that in talking to so many of you in the past 2 days, you've been describing to me this moral injury that you're incurring, and it makes me sad. It really does make me sad to hear my brothers and sisters in medicine feeling like they're not doing the job for their patients that they were trained to do. And they keep asking me, how can we fix this? And so there is something where we're down at the bottom rung of this Maslow's triangle hierarchy of needs. We're dealing with our physiological and safety needs now. We're not at self-actualization. And I think that there's a way to get back to that. And I'll tell you about my own personal kaleidoscope that I kind of use. But before I do that, I wanted to make you laugh a little bit. I'm big on mnemonics. My wife went to MIT and she taught me this is an easy way to remember things. So early on in COVID, people were asking me, what are the causes of COVID-related delirium? And I invented one that was called VOCDIF, VOCDIF. And the residents looked at me and said, well, Dr. Ely, if you just rearrange the letters a little bit, it's F-COVID. So we hate COVID, so F-COVID. So this is a mnemonic where you can think when somebody's brain isn't working well during their COVID disease, you can think of these lists: family isolation, clotting, oxygenation, the virus itself, being immobilized, or drugs like benzos. And if they are delirious, I wanted to leave you a tool here because the nurses invented the Dr. Dre. Dr. Dre is a pretty famous rapper, as you know. And I wrote to him to ask him if I could use his name for this. And he didn't answer, so I'm taking that as a yes. Don't get me in trouble. But it's when somebody's delirious, you can get through 90% of the differential if you just think of what are the diseases that cause this, what are the drugs I should remove, not add, and what are the environmental concerns like eyeglasses, hearing aids, mobility, day-night cycles, etc. Those are some tools I wanted to leave you with. I mentioned all this benzo use. Well, during COVID, we published this paper in the New England Journal as well, which was an extension of our original study of alpha-2 agonists versus benzos. This time we did alpha-2 agonists versus propofol, and they came out the same. So we have safe drugs and safe ways to treat these patients. There's no need to go over to the category of GABAergic benzos, which is what's happening when we know that they increase by far the amount of suffering on the back end. And one of the doctors yesterday said to me, I think we've gotten too comfortable with a short range vision of our patients suffering. And what I want to do, this doctor said to me yesterday, one of your attendings said, I want us to have our long range lens, our wide angle lens, and then look down the path at how these people are going to suffer during the months and years after COVID. And a paper just came out in JAMA today. Where is it? Got it on my desk here somewhere. That said that 1 year after COVID, that 75% of COVID survivors were experiencing physical, mental, cognitive issues, one or the other. So this post-intensive care syndrome, coupled with long COVID, by the way, is a very real life-altering public health problem for these patients. Let me leave it at that for the slides. I want to share with you a very quick video, and then I'm going to bring this to a close. I hope this volume will be loud enough, and it's just 3 minutes long, and I'll bring us to a close for Q&A.
Breath is about telling the story of real people and real research, medical history, and the personal aspects of these people's lives, bringing together this technology and touch so that they can figure out a way forward. You're going to meet some patients of mine today, Sarah Beth, Lovemore, and Titus, who was cared for at the Children's Hospital, and his mother, Allison. Sarah Beth was a patient in the early 2000s who got the old way of ICU care before we had the ABC DEF bundle.
A friend of mine took me to the emergency room on Memorial Day night where they admitted me, then spent 33 days on a ventilator. Both my kidneys failed and I went on dialysis. My memories of that time being sedated are like living in a Stephen King novel. It was nightmare after nightmare after nightmare.
Medicine had to adapt over time so that we could do a better job. If you contrast her story with that of Lovemore, who's taken care of with the new way, you're going to hear him describe early on being mobilized, awake in the ICU. And that's also the way that Titus, a 4-year-old with sepsis, was cared for.
On Valentine's Day of 2018, I was outside the library in Green Hills and I got mugged and I got shot in the stomach. They were worried about whether I'd be able to walk again. So getting me off my feet during the first week that I was in the ICU was really good.
One thing that really surprised us is, and it was a brand new protocol at that time, is getting them moving as quickly as possible. Everything improved from there.
I am proud of the fact that something that happened to me improved someone else's life when they go through an illness like that.
Finding the joy and not letting what happened ruin our lives.
Sarah Beth, that you just saw, was the index patient whose IQ we discovered, she had pre-IQ testing, went from 145 to 115 after her ICU experience. And then later on, we proved with MRI studies that she and many other people lose volume in their dorsolateral prefrontal cortex and hippocampus. They actually get brain injury that leaves them with this type of dementia. And we are now, through a $20 million R1 at the NIA, collecting brains of these patients as well in the Brain2 program. I want you to know that we're hitting this hard with science, and the science is there, but this old way, new way thing, we went from old to new, back to old. And so I want to talk to you about how to get back to the new way. And I'm just going to close to bring it back to humanism with one paragraph. And then Bob, it's all yours. Recently, I was fortunate enough to connect with author and poet Guy Johnson, son of Dr. Maya Angelou. She had been my patient earlier in the book, so I connected with him because I wanted to tell her story and get his permission. Her voice had echoed in my mind over the decades since I cared for her at Wake Forest when she was preparing for her poem On the Pulse of Morning for the inauguration of President Clinton. I was excited to speak with Mr. Johnson. When asked what it was like to grow up in the shadow of his mother, he responded, "I grew up in her light. Sometimes I wasn't worthy of it, but it has always been an experience that expanded me." I sensed this graciousness, this wise humility when we spoke, and I told him with a schoolboy's enthusiasm about the way his mother's words had reached me and struck a chord in my life. He told me, "My mother said she always wrote from the Black perspective, but she aimed for the human heart." So, Bob, that's how I bring this to a close. We have to aim for the human heart and remember that our patients are our North Star. And if we are doing things in our practice that aren't evidence-based because of some mentality that developed during COVID, we're going to have to unlearn that. And in Tao Te Ching 65, they teach the masters, teach them to unlearn things. So we're going to have to unlearn these new habits. And Bob, I trust your leadership there at UCSF to help me figure out a way to do it as well. So thanks everybody for your attention and time.
Thank you, Wes. That was spectacular and both incredibly instructive and also uplifting. I've got a few questions myself and others are coming in. Let's start with one of the places you ended at. It sounds like we don't know very much about why people's brains take such a hit in the ICU. So what have you learned and what are your hypotheses about what actually is happening?
Sure. I think that you have, the most common disease up in the ICU is sepsis, and sepsis is a very thrombophilic disease and one which is bridled with unbridled inflammation. So I think there's a lot of downstream problems from capillary bed thrombosis where cells are getting ischemic, but then they're also getting bathed in some damaging, inflammatory mediators. And then in addition to that, we pour kerosene on the fire with our drugs, which are too heavy-handed. So but of those things, the most iatrogenic and therefore modifiable piece is getting rid of the heavy-handed sedation and getting the patient out of the bed and getting rid of the delirium. So that's where I start. And that's really what the whole bundle aims at, getting you awake and alert and out of the bed with your family at the bedside. There also are some great data, Bob, from Brazil showing that the more family engagement you have, the less delirium you have. So in addition to the mobilization, there's something intangible we will never measure about having your loved one whispering in your ears and helping you find a why to live. Kind of Viktor Frankl's, if a man has a why to live, he can get by with almost any house. So helping people find their why again.
I'm sure early in your research there was pushback about under sedation and sort of being terrorized by being in the ICU and being sort of partially awake and seeing what was. How did you address that? How did you answer that? And is that a risk? Is there a risk you're going to undersedate somebody and that may cause its own version of harm?
Thanks for that question. We had a lot of pushback. When we first presented our ABC study in Berlin, and this is told in EDDB, I sent a new attending over there to Berlin, and he just got crushed by the senior attending in the room who said, "You're stopping sedation? That's ridiculous. There's no equipoise there. You're going to harm people and cause more PTSD." Well, we studied it after that. We went and studied it. We published in the Blue Journal and numerous other papers. No increase in PTSD, no increase in depression, so no harms there. And then from a physical perspective, what happened was that patients actually did have an increased self-extubation, but there was no increase in reintubation. So the patients were right and we were wrong. We just needed to wake up to the fact that they were ready to move on from life support.
I was struck by your story of Teresa and seeing the patient outside of the ICU weeks or months later and understanding the harm that the intensive care unit stay had. I'm guessing most of our people who work in the ICU never do that, never see someone in post-hospital follow-up. First of all, how do you do it? How does it sort of bake into your schedule? And is that something you recommend for people in their career or at least during their training phase? Do we need to be able to show them the long-term follow-up in order to make it tangible?
Well, your Dr. Santos is beautifully developing post-ICU clinics. So at UCSF, you are developing this ability, and we thank you so much for that service to humankind. At Vanderbilt, Carla Seaven and Jim Jackson, for example, lead an ICU recovery center here, where basically anybody who's had delirium, been on the ventilator or septic, we think they're going to need some transition period now. They can't go back to their primary care doctor straight away, well, they can, and there's a lot of primary care doctors on the call here today. What I would say to you is just remember that they've been in the unit and find out what happened to them. What we found is that when we didn't make a warm handoff, that the primary care doctors who were receiving them didn't understand the type of injury that they had incurred, and they were at a disadvantage. So we have to increase our communication so that we all are talking to one another on the patient's behalf. And I think the way I said that may have come across as negative, and I apologize if I did say that. What I meant to say, give me a mulligan and a do-over, is just this. We need better transitions of care from the ICU back out into the world for these people. And if that means an ICU recovery center or a post-ICU clinic, then so be it. Or for you extremely, agile and adept primary care doctors, for us to tell you what you're going to be looking for in each individual person.
A few questions relate to some of the things we did deal with during COVID, and I obviously still are. One is someone says, thank you so much for your talk. One of the things that's impacted my patients the most was the lack of family contact due to visitor restrictions. What are your thoughts on how we can mitigate the issues caused by this type of isolation? And then probably a related question, would you please share some tips about how to make connections with patients in a world of increasing televisits? So in some ways, two sides of the same coin.
Well, one of my patients in COVID was Jimmy Johnson, and he did not have any visitation allowed, and he was in prison, and so they had him shackled. And I want to tell you this quick story because it'll speak to the need of family. I think that absence of family is anti-medicine, and I think that we cannot treat family as a luxury. Family are part of the treatment program for our patients, and I wonder how many people died of loneliness and absence of family during COVID because they simply couldn't realize that they had a reason to keep living, a raison d'etre. So Jimmy was shackled. We managed to get his shackles off, pull his knees up. He felt like a person again. And we managed to get his sister there, who he hadn't seen in 2 years. We thought Jimmy was dying. And, I mean, as sure as you can be about somebody's dying, we were preparing palliative care. Everything about his life was comfort measures and, taking the ladder from cure a wall to comfort wall. And a year and a half later, Jimmy is still alive. I think we loved him into existence. And I think that we have to say to ourselves, we made a mistake during COVID. Absence of family visitation was an outright mistake. It was anti-medicine, and we can't go back to that because it injures us too. It injures the family and patients, but it also injures us and leaves us without a burnout prevention program. The family and that connectedness is my burnout prevention program, and I get so much love. And the televisit question is this: how to do it? I think it's the same way that I do it right now, which is I have to kneel down, hold hands, look in eyes. So in tele, it's looking in their eyes, saying, not what's the matter with you, Miss Smith, but what matters to you, and switching that preposition from with to to. What matters to you? I need to know your pet's name. I need to know what kind of food you like and your favorite music. And if you tell me that, then I can't see you as a set of lungs or kidneys or an organ dysfunction. I've got to see you as a whole person. And that makes me into the healer that I think is my vocation.
Yeah, let me follow up on that because I think it is really one of the profound questions in the intensive care unit where, obviously there are now EICUs and people managing intensive care units from a distance through telemedicine with more and more data streams coming in and more AI being applied to them. You can imagine a world where it really is mostly physiologic tinkering of dials. And so, as you train young people going into the field of intensive care medicine, how do you ensure that they remember the humanistic part of it and they don't do something that might be fairly natural to do, which is to say, I'll sit at this control panel and manipulate the dials, and that's what the main part of my job is in taking care of these people.
Yeah, our young physicians and young team members, they are so smart, obviously, whip smart. At UCSF, I'm just blown away by who you attracted to your medical center. So they love numbers, they love dials, they love data, they love science. And so I want to lead with science in the answer to your question, which is if I say to somebody, do you want to see this person? If you want to see this person, then is it okay if they're delirious? Because if they're delirious, how can you talk to them and find out what matters to them, right? So with all this delirium, how can you get them out of that delirium? And the data show clearly that the two best interventions to get somebody out of delirium are to mobilize them and to have their family there. That's by far the clearest thing. It's turning off, but to do that, to mobilize them and have their family there, you have to unsedate them. So these things are all linked together, see? And I know that you're closing your ICUs this summer. I think that's a beautiful thing to do, not to say that the doctors, the hospitalists and the other doctors who were taking care of the patients weren't doing a great job, but the data will show that as you can standardize and reduce unnecessary variation in care, that you're going to be able to build this, get back to this 80% compliance rate with these steps and this A2F bundle. And the way to do this is to talk about it on rounds. And this is going to seem manual, but let me close with this to answer your question. So what I tell the house staff is, on rounds, outside or inside this room, we have to hear from the nurse. The nurse has to tell us, here's the target RAS, the actual RAS, the CAM, here's what I'm doing today with mobilization, and here's what's going on with family visitation. That's essentially the bundle. It's super fast, doesn't slow me down, but I want the nurse to say it, and then I want you as house staffers to engage in that and say, how can we build that? Because we know in 25,000 plus people, New England Journal, JAMA Lancet, heavily evidence-based, this saves lives.
Thank you. Question this from Steve Panlot, who runs our palliative care service. He says, we often see people receiving critical care and some, if not many, won't benefit. How do you think about goals of care conversations and how does it fit into your bundle?
Well, I consider myself a primary palliative care doctor, and I appreciate so much the secondary palliative care that the professional consultants offer us. And we work hand in hand all day long with our palliative care subspecialists in the unit. So we're all just doing this all day long. But what I think about constantly is that, you know, in a medical ICU, 1/3 of our patients die by the time they leave the hospital or shortly thereafter. So I'm not doing my job if I'm not paying attention all the time to, if this patient doesn't survive, have I provided the level of healing that is required during the dying days? And you heard me right, healing during death. Because as I said earlier, my working definition of mercy is to dive into chaos and provide healing, lifting and healing. So during those dying days, how can I help them reconcile relationships? How can I help them see their loved ones? And I do the 3 Wishes Project. Let me just tell you a real short story. 2 weeks ago, I was on service and I had a woman, and she allowed me to use her story. Her name is Flo. She's signed a release for this, but she was dying of pulmonary hypertension and biventricular failure. And I said, well, you get 3 wishes. What do you want? And Deborah Cook invented this. You know, Deborah Cook, famous intensivist. But I've used this now all the time on my patients. And she said, well, my 3 wishes will be this. I haven't tasted salt in 5 years because of my blood pressure problems. So I want a pizza. And I said, how about pepperoni? So boom. She said, secondly, I want to see all my family. So we broke our family visitation. We're open, but we don't have like 20 people in there. So we had 20 family members in there. Okay, yell at me. I don't care. They were all in there with this dying lady. And then she said, I don't want to go home tomorrow because that's the day I'm going to die, and I don't want it to be on my son's birthday. So I said, all right, you've got all 3 of those. I'm giving you a bonus wish, which is we're going to throw a birthday party for your son in this room. That to me is medicine. And the bundle is what made it possible, because with the bundle, she wasn't delirious and could tell me that. And that to me is why the bundle is also palliative care.
Yeah. Wow. That must have been quite a scene.
It was.
Laura Perry, who's geriatrician, talks about the burnout rate of geriatricians, and then she says, now our workforce is hemorrhaging with no hope in sight of meaningful change to prevent future losses. How do you propose that we manage the workforce shortages to rehabilitate the masses of patients post-COVID ICU on a population scale? I'm not sure that's answerable, but I'd love to hear your thoughts about that.
Yeah, well, first of all, we haven't said this, so let's just say that you know, PICS and long COVID. So I actually, at the beginning, I really thought, well, isn't all of this some version of PICS? So isn't PICS included in long COVID? But I've had patients who have gotten just PICS and just long COVID and both, and they've made an absolute believer out of me that, you know, 30 days, 90 days, 100 days later, you can have a de novo element with your immune system leading to all these PICS disturbances, POTS and brain fog, et cetera, even for people who never got that sick. So I had a piece in Stat News about long COVID and the silencing of long COVID patients. And my answer to your question is that we have a public health problem on our hands, and it's of a very large magnitude in that millions of people are going to have PICS and long COVID or both. And we first need to start naming it. This paper that came out in JAMA this week from the Netherlands never used the words, it was 1 year outcomes after ICU COVID. They never used the term PICS and they never used the term long COVID. We need to start calling it what it is so that people can feel some identity of what they're carrying around with them. And then in clinics, we're going to have to equip our primary care workforce to be reimbursed well, to have billable time for these people, because they're going to require talking time. I think we have to rethink this issue of not reimbursing people for the amount of time they spend with these patients, because without answers to how to cure long COVID, what do we have to offer? Ourselves. And the fact that we're willing to listen. And I won't abandon you, a compassionate statement. I don't know what long COVID is just yet in you. I don't understand your suffering, but I won't leave you. And that takes time. And so the clinician is going to have to reimburse for that.
Yeah. You talked early on about moral injury. And in some ways, as I think about that conflict between what we know is right and what we're able to do. And then I think the examples you brought up were largely related to family visitation and maybe some of the things that we do with sedation. But it strikes me there's another form of moral injury that's been difficult for folks, maybe worse during COVID, which is conflict with patients, conflict with families, people demanding care that we don't believe is evidence-based or choosing not to be vaccinated, and that lands them in the ICU. So you just talk about that, my friends from high school who liked conflict became litigators, and those of us who went into medicine mostly don't like conflict. So is that a part of what you're seeing, and how do you think about managing that?
Yeah, another story that I have permission to share is that I was with a woman. She had a high flow nasal oxygen cannula on, and she was crying in the room. And she said, "Doctor, I didn't get vaccinated. And I need you to tell my family to go get vaccinated because I was wrong." And I said, "Well," she goes, "Do you want me to tell you why I didn't get vaccinated?" And I said, "Well, it's your story if you want." So I knelt down with her. I held her hand. I looked in her eyes. And of course, I had my PPE on and everything. And she said, "Doctor, the man on the TV," and I quote, "the man on the TV said that they were trying to depopulate society of people like me. So I didn't get the vaccine." So I'm looking in her eyes and I'm thinking, this woman is an absolute victim. And the people who are yelling at me too about ivermectin, they're victims too, because there are people out there, in fact, doctors that are colleagues of mine that I've known for 20 years, spewing all sorts of nonsense out there. I don't know where they're getting this information, but it's not evidence-based. So my approach, Bob, is to say on an N of one basis, I've got to bring love to this person. And if they're spitting on me or whatever, that's not about me. That's about what they're going through and their suffering. I go to Al-Anon because a lot of people in my family have suffered from addiction. And what I've learned is that when things are coming at me and attacking me, most of the time it's not about me. So with that lens on, I can meet my patient where they are and try and ask questions rather than tell them what I think. And that's what I do is I start asking questions and listening. And I said this earlier today, but the words listen and silent have the exact same letters.
I think that's a nice note to end on. And Wes, thank you for the work that you have done and are doing, and for educating us and visiting us, and the passion you bring for the work. And I think you get us to think about what we do every day in a very different and importantly different way. So thank you very much for doing that. And thank you for taking the time to visit us.
Thanks,
Really
everybody.
appreciate
And feel free to reach out to me anytime at our website, which is icudelirium.org. We have free support groups for COVID patients. Your patients can come to our support group for free. So let us know, and I appreciate your time today, and thank you.
Fantastic. And we'll see you next week for a COVID Grand Rounds. Thanks so much.